Yes, sir. Sir is with the DG, sir.
Okay, so let us start today's event. Good afternoon to all. Respected to our session expert, Dr. Gagandeep Quatra, Madam, Additional Professor Pharmacology, AIMS, Bathinda, or esteemed these nodal officers from the institutes and those concerned officials who are attending here in today's webinar. Today's topic, that is the medication errors. These are very much aware to all of us also, and these are considered very, this common also, but it is preventable. And for a session expert, the secretariat would like the nodal officers and the concerned officials also, and to chart out what are the things that we can do in this topic, in this area, which is essentially very important pillar for the patient safety concern. Not only that, the ways how we can address the mechanism which leads to the errors. And I think Madam will be explaining on these two areas also, and we can imbibe in the this our operational action plan also. And the nodal officers from the institutes can also endorse that updated could be you have could be updated, or if not developed also could be developed. And if the this nodal officers share us the secretariat on these these action plans that are developed in the institute, I think that can be collaged together, that can be we can bring out a better decision also, action plan also in this area. So with these few words, I would not like to take much time. I would like to request request Madam to continue to start the sessions, ma'am. Please, ma'am.
Thank you, sir. Good afternoon, everyone. Are my slides visible?
Yes, ma'am. Please go ahead.
Thank you. So good afternoon once again, everyone. And greetings from AIMS Bathinda. And at the outset, I would like to thank the organizers for this opportunity. In 1999, the Institute of Medicine estimated that 44,000 to 98,000 medical error deaths occur annually. In many ways, this was the first comprehensive report which looked at medical errors. And of the medical errors, medication errors are a significant part. As per another report, there is one medication error for every hospitalized patient per day and 1.5 million preventable adverse drug events per year. Medication-related harm may be the cause of about 1/10 of hospitalizations, and about 1/5 of patients admitted to hospitals experience medication-related harm. In developing countries, the probability of patients being harmed in hospitals is higher than it is in the industrialized nations. As per a WHO systematic review published in 2022, which looked at the global burden of preventable medication-related harm in terms of prevalence, nature, and severity, they found out that the pooled prevalence of preventable harm was 5%, so that is 1 in every 20 patients. 1/4 of the harm was severe or potentially life-threatening. The prevalence of preventable medication-related harm was 7% in 30 of the studies which were included from the LMICs. Such errors negatively affect the patient's confidence in the healthcare system. They may result in additional hospitalization, infections acquired in the hospitals, lost income, disability, and litigation costs. These are costly to the healthcare systems, to the patients and their families, and the healthcare workers who are often called as the second victims. Now, WHO has an initiative in the form of the Global Patient Safety Challenges, Medication Without Harm, and other organizations across the world have started campaigns to initiate activities to promote patient safety. In our own country, we have the Pharmacovigilance Program, the National Patient Safety Implementation Framework, which is in place to ensure that we are practicing safe medication. Now, with this background, in today's session, we'll start with defining what are medication errors, explore how these medication errors happen, what are the measures we can take to prevent these errors, how technology can be used to prevent medication errors, and how these can be reported. So there are several definitions of medication error. I'm using the one from the National Coordinating Council for Medication Error Reporting, which is generally well accepted. So medication error is any preventable event which may cause or lead to inappropriate medication use or patient harm while the medication is in the control of the healthcare professional, patient, or consumer. Now, how do we classify these medication errors? Again, there are several ways where researchers have classified them. One is simply on the basis of whether there was clinically significant or not. Others have looked at events as the time at which, the process at which the medication error happens, whether it is at the level of prescriber or dispensing or administration or at the level of monitoring. This system looks at medication error in terms of whether the patient had any harm, needed any monitoring or medication for the medication error which took place, and what were the outcomes. So when we look at this, it is categorized from category A, where there are events which may cause harm, but there is, sorry, it starts with no error and moves on to this category which you see in yellow, where there is an error but no harm to the patient. And then the next category is where there is harm, there is error, there is also harm to the patient, but either it is temporary, did not require much intervention, or patient needed to be hospitalized or extended hospitalization, or there is permanent harm. And the last category is where the outcome is patient's death. Now let's look at how do these medication errors happen. Medication by itself is a complex process which involves several steps and different healthcare professionals. So when you look at these steps, starting from selection and procurement of drugs to storage, administration, and monitoring, errors may happen at any of these steps, but studies show that majority of the errors which are reported happen at the level of either prescriptions or during the administration. Now, when you look at this steps or stages at which errors can happen, they may happen at any of these. For example, when we are prescribing, failure to consider patient's history of allergy or patient's comorbidities or other drugs that the patient may be taking, or when we do not have adequate knowledge about the drug that we are prescribing, or unmindful of the contraindications to the use of that drug, errors may happen. We are all too aware of errors which happen because the prescriptions which are handwritten are illegible. Dispensing errors happen when wrong drugs are dispensed, when there are similar looking drugs, wrong formulation is dispensed, labeling is wrong. Administration type of errors happen while in the inpatient, or when patients wrongly take the wrong dose, the wrong drug. It may be a wrong route which is used. The dosing frequency may be correct. Sometimes there may be omissions when the dose is not given, or sometimes a drug which is not prescribed is given, or the wrong timing or frequency is followed. We may prescribe correctly, but at times we fail to monitor the therapy either for safety or efficacy. So, for example, when anticoagulants are being prescribed and we fail to monitor the patient, then that is again another error which happens. Now, why do these medication errors happen? Most of the times when we look at these errors, these happen because of a failure of our system. And there are several contributory factors here which may lead to errors. For example, when we look at this human factors, it may be inexperienced personnel, either as clinicians or pharmacists or nursing officers, inadequate training. When there are a lot of patients, there is overload, we are multitasking and distracted. It may be fatigue or underlying illness or the influence of drugs or alcohol. All of these may contribute towards medication errors. When we look at the system, it may be because of understaffing, when there is lack of adequate data to support the clinical decision making and prescription of drugs, when we don't store the drugs properly, or when we have a workflow which is not suited or well designed, and when the organization or the institution does not have a safety culture in place. Then there are errors which happen because of the medicines themselves. For example, those which are high risk. Sometimes administration errors happen because of, for example, ambiguous labeling. And then we have some patients who are more vulnerable to developing medication errors. For example, those who have multiple comorbidities and are taking multiple drugs, patients who are older, children and babies, those who have memory problems and there may be mistakes in taking their medications, patients undergoing high-risk surgeries, pregnant and lactating women, patients who cannot communicate well. Sometimes it may be a language barrier between the prescriber and the patient, which leads to a medication error. Now, how do we plan for safe medication practices? Now, these practices begin when we place medication safety as an organizational and departmental priority and implement a system which supports these practices. So, what are some of the key elements that we need to have? So, we need to first in our organization build a culture of safety on the basis of the principles of just culture, which is supported at all levels of the organization. The principle of just culture focuses on the system and it builds in system. It encourages employees to design a system which minimizes the risk of errors. And when these errors do happen, then how do we report and how do we take action on those errors? So what we need is a systems-based approach to address these errors. The traditional view has been to whenever there is a medication error which is reported, we attribute it to a person. We put the blame. So that is our brain kind of an approach. Now, when we use that approach, we don't look at what were the underlying factors which led to this error taking place. And in doing that, we fail to look at the system which underlies this, and we are not able to address the root cause of the problem. To have these systems in place, we need to have an interdisciplinary medication safety team and an event reporting system which assesses these risks and tries to reduce them. And also it is important to have a continuous improvement philosophy regarding the evaluation of errors and harm and strong design systems which can assess and reduce the risk of errors. Now let's look at some of the key things. Because of the short time available, I'll only highlight some of the key features and not go into exhaustive details of how we can reduce the risk of these errors. So I'm starting with how we can prescribe more safely. So written prescriptions should be legible and written in capital letters to avoid misinterpretation. As far as possible, prescriptions should be typed and printed to avoid errors of interpretation in terms of the drug names, the dose which is written, decimal places, abbreviations which are not standard. So all those problems will be taken care of. The drugs should be preferably prescribed using the generic names. If the brand name needs to be written, both these names must be written. And when we write our prescriptions, we need to tailor them to the individual patient and consider the underlying factors, the other diseases, the underlying disease processes, and the medications that the patient may be taking, any history of allergy, other drugs that the patient is taking. At this time, we must ask for a detailed history for medications that the patient may be taking. Over-the-counter medications, dietary supplements, complementary medicine which patients may take, or if they have been prescribed medicines, but they are not actually taking those. So only once we get all these details should the prescription be written. Consider drug-drug and drug-food interactions or medications that can be stopped, medications which may be causing adverse drug reactions. And we must be very familiar with the medications which we prescribe. If we need some more information, we should use reliable evidence-based sources of information for unfamiliar medications. Communication to the patient is very, very important. So when you write a prescription, we need to very clearly ensure that we give all the details to the patient regarding the use, about the safety, the adverse drug reactions which may happen, and what actions to take when the patient does have ADRs, how to report what. Now, I'm going to bring about the concept of the high alert medications, drugs which have a high risk of causing significant harm when they are used in error. So this kind of errors may happen at the time of prescriptions, dispensing, or administration. Now, it is not known whether when we use these high alert medications, the risk that there is a higher incidence of medication errors because of the use of these medications, but certainly the consequences of an error because of these kind of medicines is more harmful for the patients. So this is the current list of high alert medications which has been released by the Institute of Safe Medication Practices, and this list is continuously updated, and institutions can develop their own list based on this list. Another safety measure which has been used is to use Tolman lettering for drugs which have similar sounding names. For example, bupropion and buspirone, which may cause some confusion and the patient may be either dispensed or administered the wrong drug. Storage of medications is another area where medication errors may happen. So workplace, whether it is the pharmacy outlets, or the ward storage areas must be organized. Drugs which are similar looking, drugs which have similar looking formulations with different strengths need to be stored safely. So the person who makes this storage needs to take time to store them and be mindful of the optimal storage conditions for the medications that we are storing. So these are some examples of drugs which have a similar sounding name or which look alike. So when we are dispensing, when we are administering these drugs, medication errors may happen, and so we need to be careful here. At the time of dispensing, the pharmacist must confirm that the prescription is correct and complete. Whenever there is a doubt, then they must check back with the prescriber. Be very careful with the abbreviations which are used with the decimal places so that wrong formulations are not dispensed. Distractions at the workplace may lead to some errors as well. And while the dispensing takes place, the patients must be given a counseling and explained how to take the medications appropriately. Now, studies show that medication reconciliation, which is not done adequately, leads to a large number of errors, especially at the time of transitions in care. So, medication reconciliation means comparing a patient's current medication orders to all the medications that the patient had been taking before any care transition, which means at the time of admission to a hospital, transfers between the wards, or at the time of discharge. So how do we do that? We look at the current list of medications, develop a list of medications which need to be prescribed, compare these two lists, make the clinical decisions, make a final list, and that is what we communicate to the patient. So it should not happen that because of the transitions that happen, patients either miss out on taking some medications which are prescribed to them, or that there is a duplication because the patient did not understand that those are already listed in the final prescription which is handed over to them. Safeguarding the administration of drugs. So before any drug is administered to the patient, we need to ensure that the right patient is getting the right drug, through the right route, at the right time, at the right dose, and we are correctly documenting this. Omission errors happen when we don't document a dose which is administered to the patient. Separate storage for look-alike and sound-alike drugs and high-risk medications is recommended. All medications which are prepared must be labeled. Whenever we find anything which is unlabeled, should be discarded to avoid any errors. And preferably, medicines and labels should be verified by two separate nursing professionals before administration. And there must be an ongoing training program for the look-alike, sound-alike, and high-risk medications and medication error reporting. All institutions are recommended to have their own list of the look-alike and sound-alike drugs so that these can be referred to. So let's now look at some of the health information technology which has been used to prevent medication errors. So now we have computerized order entry systems which allow the prescribers to directly enter their prescriptions either in the OPD or in the IPT settings. These may be linked to the electronic health records of the patients. E-prescriptions may be a standalone system which allows electronic ordering and transmission of prescriptions via a system. Now, these systems make the prescribing process more efficient. They reduce the risk of errors which happen because of illegible handwriting. And if these are linked to this computerized decision support system, then they can help to prevent errors in doses. They can help the clinicians to make a real-time check on possible drug interactions and any dose modifications which they may need to make when they are prescribing to, for example, patients with a renal disorder. So such systems are slowly coming into our hospitals, and some of us are already using the e-prescription modules. There are other systems which are there for dispensing of drugs. For example, the automated drug distribution cabinets, which are enabled with the barcode scanning. So, all drugs which are dispensed from the pharmacy, whether these are oral formulations or IV formulations, all have a barcode scanner. So if a wrong drug is scanned, then there would be an alert. There are barcode assisted medication administration systems. There are smart IV infusion pumps which have a two-way interface which is connected to the medical records. So the organization can pre-fill the dosing, and when an error is made, it gives an alarm. The alarm, there is a soft alarm which can be stopped, but there is another hard stop which will prevent the error from taking place. Of course, there are errors which may happen even with these smart systems that are coming up. So, for example, there is now this technology which is coming in of wearable cameras which can allow us to detect medication errors. So, how do we report medication? We can report them if we look at them as opportunities to assess our practice, to find out what went wrong, what are the systems which did not work, learn from the mistakes that happen, and make suitable changes. So I'll quickly mention some of these systems which have been used. A common one is a voluntary reporting of incidents by the healthcare professionals, patients, or their caregivers. So this can be done using a paper-based by sending an email or using computerized systems. These are easy to implement, generally inexpensive, but there is a lot of underreporting. Underreporting happens because either there is a culture of blaming an individual, so we try not to report, or there is no penalty. Patient chart reviews can be done, which can include reviewing the patient's medical records, their discharge summaries, pharmacy databases, and the lab data. This kind of a review is conducted by people who are healthcare professionals and have been trained to conduct such reviews. These cases are evaluated independently by two or more experts. And when we put this system in place, we need to define and give inclusion and exclusion criteria. These can be used to detect all types of incidents, although they are more useful for detecting the adverse drug events and mainly those which are generated at the level of the prescribing and monitoring processes. Dispensing errors and administration processes will not be picked up through these kind of chart reviews. The challenges are in training the reviewers and the resources which we may need to do this. And the results will depend on the quality of the documentation and the reviewer's ability to capture the events. Direct observations can be done where medication administration is observed at the patient's bedside to detect any differences between what the patient receives and the medical prescription. So trained nurse observes the administration process, registers each action, and then compares that with the original physician orders. So here the observer needs to be trained and visit different units in sequence, so it is a little intensive. But it is a reliable and effective method to detect and quantify the administration errors and is valuable for detection of the dispensing errors. So prescription and monitoring errors will not be picked up. Now, what do we do when we look at all the data that we collate? Is to look at how that error took place. So unless we do a root cause analysis and try to identify all the factors which contribute towards a medication error taking place, we will not be able to build systems which address those issues and errors can recur. So a root cause analysis of all medication errors to identify what are the systems which failed and at what levels the error took place must be studied. Patients need to be also empowered to become part of this system. So they should be given information on drugs which are high risk, and especially when there is transition care, then expert medical information. So patients need to be given detailed instructions at that time. Safety instructions must be given to the patient, and what are the signs of an overdose, how drug reaction, an ADR is to be, ADRs are expected with the medications that the patient is taking, how to access medication related information. All of these are very important in empowering the patients. So to sum up, errors can happen during the process of medication, and they happen because of a complex interplay of factors. To address this and to minimize the risk of errors, we need to establish a culture of safety in the workplace. And when an error does take place, we need to identify all factors which contribute towards the errors so that we can mitigate the risks of a recurrence of such errors. And strategies to target medication safety need to target multiple points in the process, not just the end point. We often look at only the end point and we fail to look at the underlying reasons. So all those points may stay unaddressed if we don't target those multiple points. So let us all work towards improving medication safety and patient safety. Thank you.
Thank you very much, madam. I think you have covered many areas. We is also, we are revised also, because the many things are covered here. Some of the mechanisms that we wish to address, you have highlighted about the technology also, and other mechanisms we could see different mechanisms which has been addressing, which could be used. I think, man, I just from my side, I just want to know one thing. In your institute, whether who is leading these medication errors, this area, ma'am? Is it working? And some operational action plan is also going there in the institute.
So, we have started some of these activities in our institution. So slowly we are also building a culture as we are a new institution. So we are building some of these activities. For example, increasing the awareness and reporting of adverse drug reactions, conducting some training workshops for our nursing officers and other staff for how to report these adverse drug reactions. And then now we are looking at gathering data for prescription audits. So slowly and slowly we are building these things up as part of our organizational safety culture.
Okay.
So we're conducting some consumer awareness programs. We are conducting programs for our own staff, the doctors, as well as the nursing officers for different aspects,
Right.
so that we can move towards reducing
Yes,
patient
yes, you
harm.
have rightly, this address that the system approach, system development is required, which has been due to interplay of various factors, even this patient also from the health professionals also. Not only that, you have also described medicines as also the part, giving a very big significant component in this medication errors and also. So I would ask Avinash, are you there?
Yes, sir, I am there. So we are thankful on the behalf of Patient Safety Secretariat. We are thankful to you, sir, for your valuable insights, and to Gagandeep madam as well as our expert for the day, speaking on the medication errors. And we shall continue to engage AIMS Batinda, faculty from AIMS Batinda, and the other faculty members who have joined from all over the country in different patient safety activities, as and when expert expert guidance and advice is required. So thank you everyone for joining. That's all from my side.
Ma'am, please share the slides because others are also asking so that we can share the slides to the other institute also.
Yes, sir,
Thank
I
you
do
very
that.
much, ma'am.
Yes, thank you, sir.
Thank you very much, ma'am.
Thank you, sir.